You can feel fine and still have something important shifting under the surface. Energy dips, waist changes, blood sugar creeps up, strength slips, stairs feel a little harder. Today, we're talking about the hidden metabolic changes that can quietly affect how strong, mobile, and independent you stay as you get older, and what you can do about it. Stay tuned. Hi everyone, I'm Barbara, and this is Age Better. Before we jump in, I want to hear from you. If there's a topic you want me to cover, a question you want answered, or an expert you think I should interview, email me at agebetterpodcast@gmail.com. And make sure you check out my Age Better Cheat Sheet newsletter on Substack. That's where I go deeper into the newest research on healthy aging and then break down what it means for you, what matters, what doesn't, and what you may want to do differently because of it. The link is in the show notes. Today, we're talking about metabolic syndrome, a cluster of warning signs that can show up through waist size, blood pressure, triglycerides, HDL cholesterol, and blood sugar. But this conversation is not just about lab numbers. It's about how those numbers may connect to your energy, inflammation, muscle, bone health, mobility, and physical capacity. And that matters because after menopause, many women notice changes they didn't expect. More belly fat, higher blood sugar, less muscle, more joint pain, or a sense that the body just isn't responding the way it used to. Today, we'll talk about what metabolic syndrome is, how to know if you may be heading in that direction, what to ask your clinician, why muscle is one of your best tools, and where GLP-1 medications may fit for some women. Joining me are two outstanding physicians. Dr. Susan Bryan is a board-certified endocrinologist and menopause specialist with the Menopause Society. She helps us understand metabolic syndrome, insulin resistance, menopause, and treatment options. Dr. Jocelyn Wittstein is an orthopedic surgeon and sports medicine specialist at Duke. She helps us connect metabolic health to muscle, bone, joints, mobility, and staying strong and functional as we get older. And Dr. Wittstein has been a guest on Age Better a few times before. I'll include links in the show notes so you can learn more about both Dr. Bryan and Dr. Wittstein, their work, and how to follow them on Instagram, which you definitely want to do. Okay, everyone, get ready to age better. Dr. Bryan and Dr. Wittstein, thank you so much for joining Age Better.
Our
Thanks
pleasure.
for having us.
It was so great to bring the two of you together with two different perspectives about metabolic syndrome and how it can affect our physical capacity and our strength and mobility. And let's get right to it. Dr. Bryan, let's start with you. Let's talk about the big picture first. What is metabolic syndrome? And why is it such an important issue for women, especially women in their 60s?
Metabolic syndrome, it's not a single disease, but it's a constellation of cardiometabolic, kidney, liver risk factors that when you put them together increases the risk significantly of having type 2 diabetes, actually dying earlier, so increasing mortality at a younger age, having fatty liver disease, which is now called MASLD, obstructive sleep apnea, a lot of different diseases. So it's 3 of 5 things. And you can figure it out for yourself pretty easily, which is nice. But it is a low HDL, so less than 50 in a woman. It's a high triglyceride, so 150 or above. That's increased waist circumference, 35 inches in America. It's a fasting glucose in the pre-diabetes range, which is 100 or higher. If you get to 126, that's actually diabetes. So in that range. And then it's elevated blood pressure. And in this diagnosis, the blood pressure is 130 over 85 or greater. So if you have 3 of those 5 things, then you technically have metabolic syndrome. And the reason it's really important for definitely all women to understand, but certainly as you get older, is that the prevalence increases significantly with age. And it really doubles between a woman who's around age 40 and a woman who's around age 60. Your risk at age 40 is around 20% of having metabolic syndrome, but it's above 40% once you're older than 60.
Dr. Wittstein, let's talk about it from your perspective. You're an orthopedic surgeon. You're a sports medicine specialist at Duke. Why does metabolic health matter beyond everything that Dr. Bryan just talked about? How can it impact our physical capacity, our mobility, our strength?
Yeah, so metabolic health is actually incredibly tied to, well, they're very interrelated. Musculoskeletal health can contribute to your metabolic health. How much muscle mass you maintain and things like that can contribute to your metabolic health. But metabolic health certainly intersects with musculoskeletal health in the realm of things like systemic inflammation. People with obesity are more likely to have arthritic joints, both in the non-weight-bearing and weight-bearing joints. And weight loss can improve the health of non-weight-bearing and weight-bearing joints, actually. Diabetes is a risk for systemic inflammation. It's a risk for things like adhesive capsulitis or frozen shoulder. It's a risk for perioperative complications and infections. And diabetes in and of itself is an independent risk factor for osteoporosis because diabetes affects the quality of bone even more so than the density necessarily. So there are quite a lot of overlaps between metabolic health and musculoskeletal health in both directions.
Dr. Bryan, insulin resistance. I mean, people don't really know what that is so much, but it's often the underlying issue connecting all of these markers, the 5 things that you talked about before. Talk to us about that.
We think insulin resistance actually starts at the level of the fat cell. We call it the adipocyte. And interestingly, normally the fat cell is actually our friend. And it helps us because when we have extra energy, we just store it safely in the fat cell. And when we need it, it's there. If you go for a long run or a hike or whatever, you're working a long day and you need some extra, you can turn it over there. But in the unhealthy state, especially in visceral fat, which ties into aging and menopause, in that case, the fat cell becomes unhealthy and they have 2 branches of things that they do that are really bad. And the first is that they start spilling free fatty acids into the circulation. And free fatty acids are not good for any tissue. Specifically, they're really hard they're bad on the muscles, they're bad on the liver, they're bad on the pancreas. They basically cause a worse environment for any of the receptor situation with insulin to help inside the cell. So they gunk up the whole insulin reaction in the cell and a lot of important areas in our body. And then they also actually get hypoxic, so they don't get quite enough oxygen, and they start spilling inflammatory cytokines. So that's how visceral fat is also so inflammatory. So insulin resistance, a kind of basic idea of it is that insulin is the key to the lock of the cell that opens up the cell to accept glucose. We think maybe you eat something and it turns to glucose and then glucose can just go into your cells, but it can't. There's no door where glucose just enters the cell. And the cell is what needs the glucose, right, to work. The blood, where it's being carried, doesn't need glucose. And in fact, if glucose gets high there, it's bad on all of those blood vessels. And it glycosylates things. And I like to tell patients that's like adding a sticky tail to things. So you imagine now your nice blood flow is getting gunked up by all of this sticky tail. So you have to have insulin to open the cell door to let the glucose in. And when you have insulin resistance, that mechanism is not working right for a lot of reasons. So the cell is not acting correctly, and then the glucose builds up in the bloodstream. And basically, it affects all parts of our body. But that is the underlying sort of mechanism.
Right. The visceral fat, which is belly fat for anyone listening who doesn't know what that is, and surrounds your organs, very dangerous kind of fat. Dr. Wittstein, so if a woman has this pattern, but she looks fine, like she comes into, she looks fine from the outside, what might still be happening underneath the surface in terms of one of the words I've heard mentioned by the two of you already a lot, inflammation, stamina, muscle, resilience, or physical function?
Well, I mean, the tricky thing, of course, is the menopause transition, and the postmenopausal state is also associated with higher levels of systemic inflammation. And so There's generally some increased inflammatory state in the lower estrogen state, but then you have these elevations in inflammatory cytokines from the visceral fat. And then the glycosylation end products, the health of the bone, the quality of the bone also is being affected by accumulation of these products. And of course, women in the postmenopausal state are also losing bone more rapidly, and especially rapidly at the menopause transition. So, and we know, and Dr. Bryan can speak to this more, of course, that there is this coinciding change in insulin resistance that can happen at the menopause transition as well. So these things are all like colliding.
Really
Increased
are.
inflammatory states affecting joints, the synovium of joints, not just the shoulder or frozen shoulder, but also that sort of uptick in arthritis and early onset of joint pain, or earlier onset of joint pain that we see in women over men at around age in the 50s for sure.
Dr. Bryan, so many women might be saying, I'm doing the same things I've always done. And maybe I'm even doing the right things, but my waist is changing. My blood sugar is creeping up. And I feel different. I mean, this is all now I'm talking about postmenopausal. What is actually happening metabolically after menopause, and how much of this is related to hormones, aging, muscle loss, and so on and so forth?
We know that the menopause transition, as you lose estrogen, you do increase visceral fat. And that even can start a couple of years before your final menstrual period, as your estrogen is dropping. Estrogen is important for insulin sensitivity. And so what's interesting with estrogen and fat is that estrogen preferentially helps us store subcutaneous fat that's not dangerous fat. And so when we lose that, then we pivot as the estrogen goes down and we no longer preferentially store it in the subcutaneous fat, we pivot to the visceral fat. And so even if the weight remains the same, we start increasing visceral fat when our estrogen goes low. And that's when that unhealthy fat cell adipocyte issue starts going. And then aging in general, we start gaining weight in general with aging. Our spontaneous activity goes down. Probably a lot of symptoms of menopause, like joint pain and sleep and all of that contribute to just not feeling as well, so not as active. So weight gain in general happens, and then with aging, and then visceral adiposity with the menopause transition. And therein lies the issue of now all of the metabolic issues that can increase. So a lot higher risks of type 2 diabetes as you progress through menopause, high blood pressure, high cholesterol. So not just the triglycerides and the HDL, but the LDL also. Obstructive sleep apnea, much more common. MASLD, the fatty liver disease, much more common. So all of these things that are wrapped up in insulin resistance and metabolic disease, the risk of all of those really worsens through that menopause transition as you lose estrogen, and then all of the things that are wrapped up with that. And
Wow.
age.
And
muscle, which our
and
orthopod can talk about more.
Dr. Wittstein, so why is this stage of life, as just described, and all the things that are happening to women's bodies during this time, such an important time for women to really reassess and then tweak what they've been doing, reassess their exercise, how they approach strength training, mobility training, and even recovery routines? Why is this so important now?
Yeah, well, as Dr. Bryan was saying, because the natural tendency is to accumulate this visceral fat that's more inflammatory and become a little bit more insulin resistance. Your main tool to fight back that you can really be proactive about is resistance training in terms of trying to maintain and build muscle mass and improve your insulin sensitivity. That's probably the thing that is most in people's control that they can most do. And then that has other added benefits, of course, in terms of maintaining bone density, other cognitive benefits as well. So it's multi-purpose, but it's probably your most proactive tool that's under your control for trying to reduce your risk of developing metabolic syndrome.
Dr. Wittstein, let's connect metabolic syndrome directly to frailty, bone health, you already mentioned, and physical function. How can this pattern, especially when it includes more belly fat and therefore inflammation, affect the strength and the stamina, balance, walking speed, bone health, of course, bone density, and then just day-to-day function, all of which ties right back to mitigating your risk for frailty?
Yeah, I mean, I think people do generally shrink their sphere of activity if they're getting inflamed joints, if they're getting weaker, being more likely to fall and sustain a fracture. In certain phases of life, people aren't necessarily having unexplained weight loss or things like that and becoming frail in that way. But yeah, people just becoming less able to respond to setbacks, a fall, a fracture, limited mobility, just snowballing into doing less resistance training, being less active. Yeah, and just diminishing your overall ability. People who used to take the stairs, not being able to take the stairs, having trouble getting out of a chair, losing the strength to do things that are basic activities of daily living in some circumstances, just gradually sneaks up on people, not being able to get off the floor, things that you don't do routinely, of course.
Yeah, but so then let's talk about this as a really big issue. It's like a chicken and egg issue. And I've heard you call it that because on one hand, metabolic syndrome can make it harder, as we have just been describing, to stay strong. There may be some issues as a result of metabolic syndrome that have caused you to not be able to do certain things the way you used to, or exercise the way you used to, and so on. But at the same time, staying strong and active helps improve metabolic health. So it's chicken or egg. It's a catch-22, I guess, also. Right, Dr. Wittstein?
Yeah, I mean, I think that people have to constantly reassess the way that they try to stay active. What you used to do before might not be what you can do now. And that's not defeating.
Dr. Bryan, so from the endocrine side, how do insulin resistance and visceral fat, that belly fat around our middle, the deeper belly fat, affect energy, inflammation, fat storage, and muscle?
Definitely sarcopenia, loss of muscle, and diabetes and insulin resistance and the metabolic picture absolutely go hand in hand. Sarcopenia is so much more common in patients with diabetes, and we talk about it a lot. And it's one of those things that they feed in on each other. When you have a body that is struggling, it is hard. So I do love wrapping all the different services around physical therapy. And we have sports trainers, we have physical PMR, medicine rehabilitation specialists that can help. They're great for helping, like inject something if it needs it, help get more active, just all these different specialists. But because they are very much wrapped up together, the metabolic disease underlying all the ways that it impacts definitely affects muscle quality and bone quality and health. And we didn't talk about muscle quality, but we have muscle amount and we have muscle strength and we have muscle quality. Interesting, the muscles also can get fat in them and can also not function as well. And that's why sometimes you see in those studies, they have not just the size of the muscle or the lean mass, but the quality by doing the strength testing or the get up and go and all of that. The other thing I wanted to point out about muscle that's so important is that muscle is the major peripheral place that we put our glucose. So whenever you eat and you have anything that any carb, that 70 to 80% of it needs to go in the muscle. And so if it doesn't have enough muscle to go, or if the muscle isn't healthy to bring it in, like insulin resistance, then now you've got a whole bunch of glucose circulating around. What are you going to do with it? So muscle is so important. It is something we stress so much because it's going to help you with your bone density. It's going to help you with your metabolic disease. And we know you can actually start changing things pretty quickly metabolically when you start building muscle within weeks. Right away, the same day, you see some changes, but like sustained changes within just a few weeks of muscle training. These things are very important, but realistically, how they get done can be tricky when you're already dealing with the body that's having a lot of pain and has a lot of disease for different things.
Maybe it's best to try to get the 3 out of the 5 or the 4 out of the 5 or all 5 that a woman was dealing with under control before she starts doing any serious exercise.
Well, part of treating those things can be exercise. HDL, for example, that goes and eats out the junk that's in our arteries, and a low HDL is one of these things. So we have actually tried niacin and other medicines to raise HDL pharmacologically, and it doesn't work. So the only way really you can impact that good cholesterol above 50 is to lose weight and exercise. So those things actually do. And in the diabetes prevention trial, when they looked at the glucose trying to prevent prediabetes to diabetes, now we didn't have GLP-1s then, but we had metformin and some other older medicines. Diet and exercise was better than metformin. Metformin was the best medicine at that time in preventing progression to diabetes.
I also think when we're thinking about bone density, you hear all the time, like you need to lift heavy and or walking isn't enough. And I think when you're starting from a place, like if you're at a place of metabolic syndrome and you've got all this inflammation, I think starting somewhere is good. And things like walking doesn't improve your bone density, but it does slow down the loss. It does reduce your risk of falling and reduce your risk of hip fractures, for example, even though it doesn't necessarily increase your bone density. But likewise, if you're thinking about strength training and building muscle mass, there's different ways to do it.
I've heard it from so many, like a lot of the world's experts in muscle and all of that come, and they say the biggest change you're going to get metabolically is when you go from nothing to something. Anything else above that is like this. And that's where we live, all the three of us, I'm sure, we are up here and trying to do the best that we can. But for someone and that's, I think, the problem with social media, people get so many mixed messages and they don't know what to do. And they feel like, well, going for a walk isn't worth anything. Not true. Like, that's major. And if you go from the couch to something, you're going to get changes. Even that day, metabolically, things can change. So that would be one of my biggest messages.
Or even if you go on, like, if you're going on a walk after dinner, that's actually quite helpful. I always say that. I always say something is better than nothing, or you have to start somewhere. Or even on a given day, like you hold yourself to this standard and you have to say something is better than nothing. It's better to at least walk for 20 minutes and do 10 minutes of weight.
That's right. That's why they put a name to it too, exercise snacks.
Yeah, that too, yes. Yeah. Mm.
Yeah. And it is, and I'm glad that you mentioned going for a walk after a meal or after dinner, because we've seen the studies that show, especially as it relates to diabetes in particular, about how walking for about 10 minutes after you eat a meal is a very good thing to do for yourself. So maybe everyone start with that. Dr. Bryan, is it possible for a woman to have metabolic syndrome if she's not very overweight?
Yes. Normal weight is about 7% of metabolic syndrome cases are normal weight. So yes, that's what you've heard to refer to as like skinny fat. We don't really like that term, but someone who has a normal BMI. But if you look at their muscles, they're often small, and then there's visceral fat. And that we see in type 2 diabetes a lot. Patients can come in and they have a normal BMI, but they have small muscles, visceral fat, and type 2 diabetes. So absolutely.
I see that all the time in clinical. Like, I have so many patients with type 2 diabetes who have the central obesity. That is such a common pattern. Yeah.
Yeah, it's a good question. That's how body composition scales can be so beneficial. We just don't have them in normal clinics, so we're not doing them. But that's why they're urging, like, get away from BMIs and go to more body composition, because you can see those things on body composition. But the majority of people in regular America are not having body compositions done. So
exactly, you're left at BMI. Dr. Bryan, if a woman listening wants to know whether she has metabolic syndrome, I mean, you did say earlier on that you can know yourself. I mean, if you know your numbers, if you can measure your waistline, like there are certain things that you can do by yourself. But what if she's isn't sure if she's heading in that direction or not? What should she be asking?
I would call up your primary care doctor. That's right. Go to your primary care doctor, and all you need, I mean, they can measure your waist circumference, but probably you're going to be measuring it, because I don't know how often that's actually done in the clinic, but measuring that waist circumference. And then you want a fasting lab panel. So you want to be fasting, and you want to do glucose, which is I like the comprehensive metabolic panel, because that also has your liver function test in it. And then you want the fasting lipid panel. So that has your HDL, your triglycerides, and then your blood pressure, which they'll measure when you're in there. So technically, if you go in, if you or they measure your waist circumference and you get a fasting lab panel that has a glucose and your lipids in it, and they check a blood pressure, then you're going to have everything that you need for the diagnosis of metabolic syndrome. Now, if you have metabolic syndrome, you're going to want to have some other information too, like be screened for obstructive sleep apnea. The Stop Bang questionnaire is good for that. Check your PREVENT score, which you can do online. That's your 10-year risk of heart disease calculator, on and on. There's a whole bunch of other things. But just to diagnose that metabolic syndrome, then yes, 3 of those 5 things, which are pretty easy to get. And you probably already have them minus the waist circumference if you're doing annual labs with your primary, because those are typically done.
You did mention some other labs and some other tests, A1C, fasting insulin, liver enzymes, advanced lipids, sleep apnea risk. Yeah. So those are all really good to know if you do think that you're heading in that direction.
Yes, there are a lot of things to be checked in a midlife woman. And the lipid that we referred to, like the lipoprotein little a, for example, now the newest guidelines from American Heart Association are that everyone should have that checked once in their lifetime. That is a separate genetic risk for heart disease.
Dr. Wittstein, let's talk about testing, but more on the physical and the function end. So what should women be paying attention to, like simple things like how to test their strength and mobility, balance, endurance, and all that, to know if they're heading in the metabolic syndrome direction or not?
Basic measures that you could use, like the sit to stand test, how many of those you can do over a certain time period. Walking speed is another one, gait speed. In terms of balance, I do think it's a good check to simply see if you can stand on each leg for 1 minute. You can also do it with your eyes closed, testing to see, can you get up off the floor without using your arms? Cardiovascular health, can you climb several flights of stairs without being completely winded?
Gosh, they're everywhere. I remember I did an episode on them over 2 years ago when they were just squeaking out, just starting. Really more celebrities were doing them, not everyday people. And now everybody is doing GLPs.
Now, they were first approved in 2005, so they've been around for a very long time. One reason they are so highly effective is that they work in so many different ways for metabolic disease. That's part of what makes them so good. They have their own issues. They are a medication. So any medicine always comes with risks, and the benefit of them for the used the right way in the right person, I have seen, I want to say thousands, but I don't want to be too dramatic, but a lot of lives completely change. So I am a big fan. In the right person, right situation, they can absolutely be life-changing. And specifically when we talk about menopause and postmenopause and women and all of the cardiometabolic, kidney, all of the liver, all the things that worsen in this time, they do address a lot of those issues.
Who is a good candidate? Like anyone listening in right now might be saying, well, maybe I should be discussing GLP-1s with my clinician.
GLP-1 medicines are FDA approved for someone who has a BMI of 27 and above with one cardiometabolic risk factor. So we've already talked about a lot of those, but those are like obstructive sleep apnea, prediabetes, high blood pressure, high cholesterol. So if you have a BMI 27 or above with one comorbidity, that qualifies you for a GLP-1. If you have a BMI of 30 or above, even without a comorbidity, that qualifies you. If you have heart disease, then you also are qualified, and obstructive sleep apnea separately has also been FDA approved as an indication. So those are the patients where it's qualified. Where what we don't know is who exactly it helps outside of those situations, because the research has been done in those situations. So it's more tricky. Type 2 diabetes, of course. Type 2 diabetes, no matter what the BMI is, it is approved. So,
Yep. Dr. Wittstein, so for people, your patients, for example, who are using a GLP-1 and they do lose weight and maybe have some other great benefits too, as we've just been discussing, but then we've heard about that you could also lose muscle mass, and this is a concern. So what are your views on this?
I think these medications are largely a huge win for people. And of course, there are the primary indications, but like many things, there are, I think, other benefits. So, for example, the treatment of knee arthritis or joint pain, inflammation, especially in weight-bearing joints. These medications are not primarily indicated for that, but we see a lot of, I believe, direct and indirect benefits for joints. There's like weight loss that occurs that can help joint pain, but there are also these a systemic anti-inflammatory effect. And I think if you can reduce joint pain and inflammation, people can then be more active and may be able to participate in things like resistance training, which is going to help them be less likely to get sarcopenia. I think when we see people using these medications for management of diabetes, I think rather than as compared to people using the medications for larger amounts of weight loss, we tend to see more, at least I see people more impacted by the muscle mass loss with the larger amount of weight loss as compared to the diabetes treatment. But as that relates to, of course, muscle mass is related to bone health. And there's a lot of data on these medications having some direct positive effects on bone, meaning like directly acting on the bone cells in terms of increasing production of something called osteocalcin, which contributes to mineralization of bone. So there are all these things that are happening with the musculoskeletal system with these medications. So I think like reduction of joint pain and inflammation through multiple mechanisms, not just unloading of the joints, which may then allow people to be more physically active and do more strength training and lose less muscle mass. When diabetes is treated with these medications, there are so many studies showing improvement in bone density and reduction of fracture risk. When these medications are used for the management of obesity, there can be a neutral effect on bone health as long as it's paired with strength training. But if not paired with strength training, there can be a bad effect on bone health. So I think these are mostly beneficial to the musculoskeletal system, but we do have to be careful with weight loss and muscle loss and therefore bone health.
Inflammation markers were cut almost in half in two really good studies of one was semaglutide and one was tirzepatide. So, and you think about it, think about the visceral fat that you're losing. So the adipocytes are getting healthier. So you're not releasing those inflammatory cytokines. So that's all the way in which it helps. So we talked about inflammation a bunch. I just want to bring that up, that these medicines and the inflammatory effect starts quickly after they're started. So it's not just the weight. It's not just, it does secondarily with the fat loss, improve that, but directly in the immune system, like you were referring to, it has that effect too. And people will often say within a few weeks of starting it, like, oh, I feel better. And we think that's probably a lot of inflammation. Mayo studies looking at tirzepatide and hormone replacement therapy and semaglutide and hormone replacement, and that adding the hormone therapy to the GLP-1 showed more weight loss. And I think, there's insulin sensitivity thing to consider, but also I think feeling better, moving better in so many different ways just potentiates the effect of the GLP-1.
We are going to wind down now, but I have a question for each of you. Dr. Bryan, what are the top 3 things that you think that women listening in right now should do today?
I would say know your numbers. And the 5 things that we discussed are really 5 very important numbers to know. The second, I would say advocate for yourself. That may not be the primary thing on your primary care doctor's mind. So make an extra appointment or go in a different time or let them know ahead of time you want to discuss that. But you're probably going to have to advocate for yourself for those sort of things. And the third is figure out your activity, because whatever it is, whatever you can do, figure that out and work on that. Physical activity is really such a linchpin in being able to change the trajectory of how you age.
And Dr. Wittstein, of course, that leads me right into the question to you. What are the 3 top things that women should be doing physically with regards to exercise to mitigate their risk of metabolic syndrome?
My top answer in this case, as I mentioned earlier, is going to be like finding a way to do some resistance training, ideally a few days a week. I think I will go back to that point of start somewhere and something is better than nothing. So you just don't get overwhelmed and defeated so easily. And that's easy to say, but again, even if it's not the heavy lifting, even if it's just picking 4 or 5 exercises that you can do with lighter weights, higher repetitions to fatigue and doing 3 or 4 sets of them a few days a week, that would be great. I want to say build your team. What I hear all the time is people are looking for a person that they can see that can manage everything. And I think you're unlikely to find that person. That would be a unicorn. And so I think if you're someone dealing with metabolic syndrome, like ideally you would have someone like Dr. Brian, someone in endocrinology to work with, a stable primary care doctor, like that captain of your ship. If you're having specific joint pains, an orthopedist you can see, a physical therapist can be really critical to this team. And you may even want to consult with a dietitian and your women's health provider. I think you do need to build your team.
I do want to add one thing to the list, everyone listening in, is to follow both of these incredible doctors. Look in the show notes and how to follow them on Instagram will be there. Dr. Brian, Dr. Wittstein, this was an important conversation. I thank you both so much for joining me today.
Thank you.
Thanks for having us.
Bye, everyone. See you next week. Thanks for tuning in, everyone. If you enjoyed this episode of Age Better Podcast, please do a few things. First, share it with all your friends and family. Then, subscribe to Age Better wherever you listen to podcasts, including YouTube, so you never miss a single episode. Finally, if you have ideas for topics you want me to cover in a future episode of Age Better, send an email to agebetterpodcast@gmail.com or reach out to me on social media. Until next time, remember this. We can't control getting older, but we can control how we do it. Talk to you soon. Age Better Podcast is a proud member of the Sound Advice Network. Sound Advice, women's voices amplified.